10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hello, and welcome to the AI for 2022 Healthcare Summit. We hope you are ready to learn about the impact of AI on the business of healthcare and how patients are seeing better outcomes thanks to our machine collaborators. We're excited for you to meet our incredible speakers who are leading AI initiatives at some of the world's top healthcare companies. And a special thanks to our sponsors: TigerGraph, John Snow Labs, iMerit, GraphCore, Soul Machines, Integrate.ai, Circadia, and the others who made this event possible. Since we're all about artificial intelligence, we thought it made sense to have an AI welcome you to this amazing event. Without any further ado, please allow me to introduce, drumroll please, myself. In case you did not notice, I'm an AI-generated actor. To create this welcome video, our co-founder Michael Weiss simply typed this script into a text box, and then the computer did the rest. AI-generated synthetic media like myself can be used in many ways, from marketing videos to movies. People like me are considered deep fakes, but I don't really like the term myself as I feel quite real. Lucky for you, I represent just the tip of the AI iceberg. Today you will encounter many exciting innovations that are only made possible thanks to intelligent machines. I wish you an amazing conference experience. Now I'll introduce a human to say hello as well. Take it away, Patrika.
Welcome, everyone. Welcome to the AI for 2022 Healthcare Summit. We are so glad to have everyone here digitally. My name is Patrika Elise, and I'll be your MC for the next hour of the show. We've got some incredible content planned for you today. I just have a few key items to run through before we get started. This conference, as you've probably noticed, runs on the SwapCard event platform. Everything you need to have an amazing summit experience can be found right here. First, let's talk about networking. In order to find your connection request, meeting request, and conversations with other attendees, simply click on the My Event button, which you can find here. By clicking into this feature, you'll be able to view your networking conversations and connection requests, as well as see your meetings and meeting requests. Now, let's talk about the AI exhibits. The AI for 2022 Healthcare Summit features incredible AI products and services that were hand-selected by the AI4 team. Each one of these companies has the ability to help you push your company forward. Take a second to click around the virtual booths and explore what they have to offer. Inside, you can find more information about each company, as well as helpful white papers and other downloadables. And that's it. We think you'll find SwapCard very intuitive and easy to use. Now that you're familiar with the SwapCard platform and how to use it, let the AI for 2022 Healthcare Summit begin. I'll now welcome Daniel Lackland, the content producer of AI4, to introduce today's agenda and the first speaker.
What's up, everyone? We hope you are very excited about the AI for 2022 Healthcare Summit. This is an event specifically tailored for healthcare leaders interested in pushing the ball forward on AI initiatives that create better outcomes for patients. Today and tomorrow, we have our general session content, followed by our breakout tracks covering AI for specific areas such as care providers, pharma, payers, and medical devices. We also have a technical track focusing on AI use cases from a data scientist and engineering perspective. If you'd like to do some discussion over Zoom with your peers, feel free to join a town hall where you and the other attendees can discuss relevant AI topics. Otherwise, remember that you can ask the speakers questions and discuss ideas in real time during every talk by way of the chat box feature in SwapCard. Now, for our first speaker, Chris Dale, Chief Medical Officer of Swedish Health Services. Chris is a pulmonary and critical care physician and health services researcher. For the past year, he has been a part of the Providence family of healthcare delivery organizations, most recently as the Chief Quality Officer and Chief Medical Officer of Acute Care for Swedish Health Services in Seattle, Washington. He has also served as a CMO of healthcare data companies and will be joining Tegria Product Group as CMO this month. Without any further ado, please welcome Chris to the virtual stage.
Hey, thanks, Patrick. It's good to be here. I appreciate people taking the time to attend. Let me go ahead and share my screen here. So yeah, like Patricia mentioned, I'm actually just wrapping up a stint as the Chief Medical Officer for Acute Care at Swedish. I'm a pulmonary and critical care doc by background, with also a background in health services research. And I'm joining you today to talk a little bit for the next 15 or so minutes on improving healthcare and how advanced analytics and AI can be helpful in that, with a special focus on sepsis here at Swedish. So let's start off with some disclosures. So like I mentioned, this month I'm transitioning from Swedish over to a different part of the Providence organization. Swedish operates 5 hospitals in the Seattle area and is part of Providence. And I'm going to work for Tegria as the CMO of products. So switching a little bit more to the healthcare IT space, because I love so much what we're talking about today. It's great stuff. But I'll continue to work as a pulmonary and critical care doc at Swedish. But the 2 main disclosures I have are, first, that the views in here are mine and not those of my parent organizations, including Swedish Providence, Tegria, or Kansai. And that I do have a bias that I think that our future is better together with healthcare, advanced analytics, and AI. And I'm excited to talk to you about that today. But just because something can be done doesn't mean it will be done. And I really want to ground us in reality, that improving healthcare is hard. Like, so there's that quote from Paul Batalden that a system is perfectly designed to get the results that it gets. And that's nowhere more true than in healthcare. And so I'd like to talk about how, like, some barriers in terms of improving, and then ways that we can actually work through some of those barriers. And so we'll use sepsis as a tracer, because we've certainly done a lot of work. And if we Swedish are like any other healthcare delivery organization, your organization has done a lot of work in terms of trying to improve sepsis care. And I think it's taught us a lot in terms of how to use advanced analytics and AI. And I think finally at the end that there are reasons for rational exuberance, that we can be very enthusiastic about this space. So, you wouldn't be at an AI for Health conference if you didn't have at least an interest in AI. And according to PubMed and all the publications over time, you can see that that a lot of us do. That growth of AI in terms of interest is hockey stick and exponential. And that's great. Like, we should advance society. We should advance our ability to care for patients and improve our organizations. But we do need to be grounded in reality. I was flipping through JAMA a couple of weeks ago, and I came across this really nice paper in the perspectives section by Derek Angus and colleagues, looking at how organizations can improve sepsis or have improved sepsis over time. And I think we've been on a journey. I was actually reflecting that the Manny Rivers paper that came out that described early goal-directed therapy and kind of coined the term of a bundle in terms of sepsis came out about 21 years ago. So it's been a while, and we've been in this kind of blue box section for sepsis improvement, with kind of bundles and guidelines and external measure those things, like think CMS, and alerts in the EMR. But we're really at this inflection point where a lot of the more advancing organizations now are saying, okay, that's great. Like, it's good if we have an alert that fires with certain criteria, but our clinicians tell us that it's not always very helpful. And we're looking for ways that we can kind of take that next step in terms of sepsis. And so what Derek Angus was talking about was using advanced analytics is one category of improvement. We'll talk about that in our journey at Swedish here in just a sec. And another one is about pathogen and measuring why people are getting septic to begin with when they come into the hospital, and then using some measure of their response to whatever that infection is, which we won't really talk about today. But it's that kind of, the notion is going from kind of the way we've done things historically with bundles and guidelines and criteria-based alerts in the EMR to actually a little bit more intelligent ways of improving care. And we're on a journey. Like, we're a couple steps into what will be a very fascinating journey. And so, grounding us on our work here at Swedish at Sepsis. So, like I mentioned, Swedish is part of the Providence organization, and Providence, like I think probably most, all, I don't know, large integrated healthcare delivery systems, has worked on sepsis for the last 15 years. And we've done that in kind of what I think is kind of like nuts and bolts, or the fundamentals of quality improvement. We've broken the kind of the care process model for sepsis down into chunks, looking at when people arrive in the ED for the non-present on admission sepsis, and trying to come up with EMR-based alerts for that based on detecting sepsis. We've done stuff around order set usage, particularly in the ED. And we've all kind of focused on survival to hospital discharge. And it's been good. Like, we've made progress, like our mortality rates have improved, our the percentage of people who get antibiotics in a timely manner has significantly increased for us over time. Like we've done a pretty decent job. But I think a lot of us aren't really satisfied, that we're looking to advance even more. And so a couple of years ago, we looked to apply advanced analytics to the use case of sepsis here at Swedish. And we're on the Epic EMR. And so working with Epic, we use one of their out-of-the-box models, which uses not AI per se, but a complementary technique using a significant number of variables to create a logistic regression model to predict sepsis onset. And that's always a tricky thing, is like trying to understand like what you're predicting, particularly in something like sepsis. And we'll talk about that in half a sec. But at the end of the day, it had okay operating characteristics. You know, the C statistic, which is a measure of the sensitivity and specificity of about 0.7 or so. And we, in terms of workflow, link that to two things. One, to our tele-ICU. So we have a tele-ICU, or did at the time, that was kind of overseeing all of our hospitals and really provided a bird's eye view of the care that we were delivering. And then we tried to operationalize it via sepsis nurse who would get an alert if the EMR model predicted that someone was at high risk of sepsis. And we did kind of a before and after study, and kind of disappointingly, but instructively, the implementation of this model wasn't associated with improvement in our sepsis ODE mortality. And for me, it's a super fascinating tale, because it's a bit of a kind of a cautionary tale, or helping us think about how we can continue to improve. And I reflected on three different themes from that. And the first one here is that there's a difference between predicting and improving. You know, like there's the quote on there about Mark Twain and the weather, that, you know, everyone kind of talks about the weather and you can predict the weather, but no one really does anything about it. And that's part of the challenge here with sepsis. So sepsis, in some respects, maybe we should choose a different thing to begin to predict, because sepsis is very hard to even define what it is. And many people have written about different aspects of definitions of sepsis, and sepsis definitions have changed a bit over time, from the original definition to a more modern definition. And Chris Seymour and colleagues at University of Pittsburgh have done a lot of work in this area to help us define, like, what are better ways of defining different sepsis phenotypes, and what actually is the thing that we call sepsis. And I think that people who are looking to improve are faced with this dilemma about like what to predict, you know, and are we trying to predict people who have an elevated risk for mortality? Because that's of super interest to us, right? Like that's the thing that we're trying to affect, is like, hey, we don't want as many people to die of sepsis. But I would just say that when we're working on something, we got to think in terms, or we're better off thinking in terms not of excuse me, what the end outcome is, but what good nudges are along the way. And here's some work from Dawson colleagues, starting from California and then spreading out across the nation, where they actually took a machine learning algorithm and they actually tried to predict onset of severe sepsis. So as folks who are in the area, the discipline kind of know that sepsis exists on a continuum from kind of simple sepsis to sepsis that's affecting the patient significantly, and they start having evidence of that in terms of organ dysfunction, and then septic shock. And so what Dawson colleagues said was, well, what if we created a machine learning alert to predict incident severe sepsis? And they're able to do the math behind it and get the data flowing and all the super hard work that it takes to get a machine learning algorithm in play. And they came up with a model that had an area under the ROC curve of 0.952. If you look at that in the green side there on the left, which is a remarkably well-performing model. And if you look at the specificity of it, it was 0.9. And that's really, I think, a key thing, is that the model created, I think it was a flashing light that was actually pretty reliable, that when it flashed, the positive predictive value of it, you know, that actually told people something. The precision of it was very instructive. And then they launched the model in before and after sort of way at a number of institutions across the US. And if you look, and maybe it's a little bit hard to see on your screen there, but those are the big three outcomes for sepsis trials. First is mortality, the second is patient length of stay, and the third is readmission rate. And if you kind of cone in on the mortality one, you can see that the implementation of the model was associated with an absolute 1.5% reduction in hospital mortality. And that's remarkable. I mean, that says, like, with a number that would give it a number needed to treat of about 67 or so, which says that every 67 times the model fires, that actually it saves a life, which that's what we're looking for. And so I think this is a great example of a good nudge, that we have to think in terms of, well, what's the prediction that we're making and how does it actually impact workflow? And then does that lead to the improvement? And it's probably insufficient to predict things, kind of like I was saying in terms of the weather. Like I'm an ICU doc and I kind of fantasize like, oh, wouldn't it be nice if we were able to predict like, hospital mortality? And I think that we'll find that that's ultimately less useful than if we predict the nudges along the way. So the second learning we had was that the healthcare data are hard. That if you start playing around with machine learning models and look at different variables and trying to construct your model, you very quickly realize that, unlike web searches or even AI for vision for driving cars down the road, that there's a problem with data density and data sparsity. And I think about this sometimes in terms of sepsis, is that the variables you'd need to know if someone is going to deteriorate because of sepsis, they're very latent in the EMR based on workflow. So if you think about a patient coming in and vital signs being recorded, and sometimes they're directly ported into the EMR, but oftentimes they're not. They're kind of like written down on someone's scrubs, and then a while later they get pushed into the EMR. If you're looking to use notes, well, notes are great, and there's a lot of very nuanced information in notes, but they're not available sometimes until hours after a lot of the events have happened. And so that the fact that the data structure in healthcare isn't as immediate or isn't as dense as it is in other industries is something we have to kind of think about in terms of if our models are actually going to end up having the precision and having the recall that we need in order for them to be successful. And so I think there's still a lot of work to be done, and it'll be interesting to see how kind of sensors and other direct observation techniques come into play here. And there are some companies across the US working on using kind of the digital exhaust, or like if you have sensors or cameras kind of operating in your operating room or in an ICU, is there information that can be captured there that's predictive for things of interest in terms of actually providing nudges or improving care? Because again, it's insufficient to know something we must do. And the last thing to point out is that the models are very much at risk of learning bad habits. That if as I said before, that quote from Batalden, that every system's perfectly designed to get the results that it gets, that there are a lot of things in medicine that aren't the way that we'd want them if we had a magic wand and we're in control of the system. And so we can keep in mind, or we should keep in mind as we're developing models, that if we're trying to predict something like propensity to be discharged to a skilled nursing facility or need for an ICU bed, that baked into current behavior are a bunch of things that we're actually trying to change. And so we run a very significant risk of, if we're predicting things the way they are now, of predicting stuff that isn't actually the way we want things to be. And that's how come like thinking one step ahead in terms of nudges, or in terms of where in the process that we ought to predict something where someone needs information to do something different is potentially a more effective way of approaching it. And then we shouldn't overlook, and we're actually, I think to some degree, a bit negligent if we overlook very complicated issues surrounding AI models. And a lot's been written about this over the last several years in particular, about bias and fairness and transparency. And I think that those are very good things for us to kind of keep in mind, that it's easy to kind of, use data that exists in a structure, maybe in like your cloud data warehouse, and then kind of run some AI and ML models on it. But I think it's a bit buyer beware, and I think a bit more kind of maturity is needed in our industry as we kind of learn our way into how to best to make sure that our models are fair and unbiased and transparent, so that we can trust them and understand how they're used over time. And that's an area of opportunity, I think, for certain companies, and ways that healthcare systems and healthcare AI companies can collaborate. And that leads me kind of to the final point here, which is, I think despite some of these limitations, there's obviously a significant amount of reason for rational exuberance when it comes to AI and healthcare. And I was thinking the other day about this book I read a while ago that talked about necessary preconditions for Amazon. And the book, I think it was the Everything Store, made the point that Amazon wouldn't have been able to start if we didn't have a World Wide Web. That if you couldn't connect your computer to the internet, you actually couldn't have web pages to go buy things on. And if you didn't have credit card processing, you wouldn't be able to actually transfer money from your electronic wallet to the company's electronic wallet in order to pay for the good. And if we didn't have the postal service or UPS set up to deliver to basically every address in the US, like it just fundamentally wouldn't work. And I think that some of those things can be applied to advanced analytics and AI in healthcare right now. that we're actually seeing a significant rise just over the last 5 or 10 years in terms of data liquidity. It used to be things were locked into on-premises EDWs, and now as things are flowing more freely and we're developing kind of more reliable or industry standard tools in order to manipulate data, where people are able to access data in a way that's much easier and actually much more amenable to using advanced analytic techniques on, and even basic analytic techniques. I think are going through a renaissance right now, where we're finally being able to realize very, very slowly, I guess, some of the benefits of EMRs. And then the last thing there is just the AI best practices that as we continue to advance, I think continuing to think about, what I was talking about before in terms of bias, and fairness, and the transparency of our AI models. Like, we'll get to that point. Like, people will opine that it'd be nice if there's kind of like like there is on food, like a label on an AI model that described its operating characteristics and some of the things that are known about it. And there's a bunch of things, like even after a model gets into place, like being able to monitor the model over time to make sure it doesn't degrade. People have made the point that as COVID, the COVID pandemic arose, like that disrupted a lot of models, and the AI models are good for kind of repeats of the current of what's kind of happened before, but for black swan events or for significant departures from that, they're very vulnerable. So with all these things in mind, we're at a great time, and AI, I think, can significantly improve the way that humans work. And we really need to think not the AI versus humans, but humans and AI together to actually help us feel more comfortable and be able to leverage our particularly human skills to improve our care delivery environment, bring joy to people in the workplace, and also better results to our patients. So I just appreciate the time with you today, and appreciate the opportunity to talk a little bit about our journey here at Swedish, and appreciate all your questions. And feel free to reach out to me via the links below. Thank you.
All right, Chris, thanks for your insights, and thank you all for watching. Now, please make your way to your next session. Also, don't forget to check out the networking, accept your connection requests, and explore the AI exhibits. Have a great time. Woohoo!